Today I'm joined by Heather Irvine-Rundle, a senior clinical psychologist, author and director of the Reid Clinic, a psychology practice here on the Central Coast. With over 20 years of experience and a real interest in the women's health space, Heather has incredible knowledge to share. In this conversation, we talk about the most common reasons women in their 40s and beyond might see a therapist, from the emotional struggles that come with kids leaving home and empty nesting, to caring for aging parents, mood shifts as a result of hormonal changes in menopause, and coping with big life changes like divorce and the loss of loved ones. Heather was wonderful at sharing tools and strategies that are science-backed, which you can use in your daily life when you're struggling with these issues. Before we begin today's conversation, I want to let you know that at the end of the conversation, around 60 minutes, we do discuss topics related to suicide and mental health. This may be triggering for some listeners. Let's get into it. Heather, welcome to the podcast.
Thank you for having me.
Thank you so much for coming. I'm so excited for this conversation, and I want to jump straight in. And I know that we both have a passion for women in midlife.
Yes.
And one of the themes that I see repeatedly is people really struggling with what their identity is. So they've been the mum of, or they've been the wife of, or the partner of for a long time, and suddenly everything's changing. It might be an empty nest. It might be the end of a very long relationship. It might be a change in employment, but everything feels different. Or maybe everything's the same, but they just don't actually know who they are anymore. Can we jump into that? Because it is a repeated theme.
Yes.
Over and over again. What is going on?
Yeah, look, there's many aspects. Of course, as we age, we different priorities. We also have different hormones, as I don't need to tell you, and different cognitive processes that go on. So if we take, for example, identity, and if you think about a little girl that was called Shauna, you might have known her, she would have dreamt, she would have had a dream about how her life would have looked. Probably would have involved kids, pets, house, husband,
Swimming pool?
swimming pool. Okay. But by and large, it probably went to about the age your kids started school. May have extended to when they got to uni, may have, but unlikely. So what you had was a dream that only lasted so many years, and you would have worked towards that, and you would have had the engagement, you would have had the dog, you would have had the wedding, you'd have had the kids, you'd have got the house with the pool, and got the kids to school, maybe got them into high school, and it might have stretched to uni, but really after that there was no idea of what your life would look like, because most women dream of themselves and everything is sort of them in relation to a something or a someone, but it isn't necessarily related to themselves. Whereas men's dreams or males' dreams often relate to themselves and how they may have others, but it, by and large, it involves them and perhaps a car or a boat or a career, which means as relationships change, their identity doesn't move so much. And so one of the things we see for women around midlife is they haven't dreamt about what that midlife period of time would look like. And if for many of them there isn't a career or something, perhaps a hobby that can hold them in terms of their sense of identity, then it can be a very difficult time because they don't know what this was meant to look like. And certainly we still have this idea of women as being community givers, as being in relationship with someone. And that tends to be our estrogen. It tends to be a lot of the ways that our brain works because, we're the caregivers. We relate to others and we're very good at it. But when it comes to self, so when I work with women, we do identity work and I get them to tell me their top 10 values. Now, it's always funny because when I do that and don't give them any more instructions, their top 10 values will always be relationship values. So they'll be kindness, caring, honesty, those kind of things. But all those things are in relation to someone else. So I say to them, okay, but what about if you're on a desert island? There's no one else there. What would your values need to be? I can give you anything that you like. And often for some women, it's the first time they really thought about who they would be if it wasn't in relation to someone else. So then you get these ideas of creativity, or it could be religion, or it could be that it comes in the form of nature. But A lot of them haven't thought about it before then. So a lot of the work that I do with women is about saying you're allowed to choose 5 that are to do with other people and 5 that are just to do with you. And that can then become the platform under which they start to really get these sense of self going that's not just in relation to others.
I love that because that really resonates with me because, and I'm sure people listening, because I've literally just had a birthday that coincides with Mother's Day. That's not great, by the way, 2 for 1 and all that. And I get asked the same question by my 4 kids. Every time it comes up to a birthday, they always say, we don't know what to buy you. What do you like? What are your hobbies? And, whereas with my husband, who's pretty much obsessed with boats,
There you go.
no one has any dilemma as to what to buy him. It always involves boat shoes, boat jackets, things for his boat,
Yep.
compasses, books. And the reality is actually, sadly, and it is a bit sad that no one can think what to buy me because I think, well, what is my hobby? And it's like, well, I really love our dogs and
Yeah.
I really love my kids. But
And they're all
actually,
about relationships, aren't they?
and so no,
Yeah.
and so for my birthday, I got lovely presents, but they were like mugs with pictures of my dogs of my kids on them.
There you go.
And so that actually, your answer wasn't long-winded. It actually really struck me because I'm like, okay, this is me.
And if I present at conferences, and I will say to the group, because it's often parents, which means there's a large proportion of women there often. But anyway, the point's still the same. That if I say to the group, look, men, can you tell me what's your toy? None. I mean, above board stuff. But what's your toy? What do you enjoy doing? They will name fishing, they'll name cars, they'll name soccer, they'll name footy, they'll name something. And I say, okay, women, what's your toys? What do you enjoy doing? What's your play? How do you play? And they all look at you quite blankly, like I'm not sure, because the things that they play with are the kids and the dog, and they make family arrangements, and so it's to do with others. So it leaves us in this position where when we don't have the others, and I know that one of the big things in midlife is, of course, preparing for or in the midst of empty nesting, when you don't have that focus because you haven't seen yourself living in your home alone when you were a little girl. I don't think that was part of your dream.
No, definitely
It
not.
wasn't. You didn't see yourself swimming in a swimming pool on your own, I'm sure.
No,
No. It wasn't you didn't want the pool for you, did you?
no.
You wanted the pool for your kids.
Yeah.
And so this then, what do we do when the kids leave? Because we haven't dreamt that far. So it's a very difficult time for women.
Yeah, absolutely. I know I've got 4 children, and I know whenever my first son, even he went overseas for about 6 months, and I genuinely had like a hollow pain in my chest for 6 months with him not being in our
Yeah.
house. It didn't seem right. It didn't feel right. It was like someone was missing, and obviously he was off living his best life, which was amazing. I'm like helped him organize the trip. I was very
That was the
supportive.
plan. Yeah.
But it was awful. And I think, and I've now currently got 2 at home, and I think, what's it going to be like when they go? It's going to be awful.
Yeah. That real sense of loss, as you say, a real sense of grief, and getting to know yourself as something other than a mum.
Well, because I often used to introduce myself to people as I'm Patrick's mum, or I'm Grace's mum, or I'm Madeline's mum, or I'm Quinn's mum. Sometimes I didn't even have a name.
No, that's right. And I think that suggests how our identity is so wrapped up in relationships. And I mean, historically, we were known as Mrs. Such and Such, which, the translation, it just means wife of. We don't have a name in our own right. We just became the wife of someone else. And then, of course, we become the mother of the children. And who are we as an individual was something that, just wasn't relevant, I think, in society, and that became something that was a societal a process, but also very much, as we know, we've got more rights now, and definitely not where we'd want to be. But even with more rights, we still seem to involve ourselves in identity that belongs to others on many levels. Yeah.
One of the things that I feel when people are struggling with the whole empty nest syndrome is they feel very embarrassed by themselves. They feel like they know they've done a good job, and they know that that's what they wanted for their children, to be independent. And so there's definitely a sense of shame that, they don't have the right to feel the sadness that they feel. But for some women, they can feel really quite bereft. If anyone's listening and feeling like that, like, will the pain go away? Does it get better? What should they do? What are your tips and
Well, like with any grief, everyone has their own journey, and for everyone it looks different. What we are looking for is some cognitive profiling around thought processes. So, if we were to work with someone like yourself, possibly, I haven't asked you what your cognitions are, but at some point, if I dived into it, you might have said to yourself, I am sad, but I can handle it. And what you can see there is that there's a sense of this pain, but a capacity to keep going. What we'd be looking for in these mums is, can you hold the pain but feel like there's some capacity to keep going? What is the cognition that says, I'll get through this time? What is the cognition that says, every day will get a little bit easier? Whereas where I get more concerned is when I hear a woman say, I'm in so much pain, I feel like my life is over. I feel like I'm nobody. I feel like I have nothing. And they're the women that I want to work with to really challenge some of those cognitions. Of course, whenever you work with a psychologist, I'm going to go back to childhood, or a good one should anyway at some point if it's relevant. But really see when those cognitions started and how the relationship with their children might have really helped with some of the negative cognitions they've been carrying around, a sense of purpose, a sense of kind of achieving something. And so therefore why then when the child moves away, they can no longer hold those perhaps more adaptive or healthy cognitions because they were tied in with the children rather than within self.
And probably a lot of the cognitions behind all this has been developed from an early age, in that you've probably been sort of set up to be a carer your whole life.
Yeah, and as many women are, I mean, we are often congratulated on being kind, congratulated on putting people before us, congratulated on serving somebody else. And whereas men are often congratulated on achievement, on individuality, on putting themselves above others in order to get something done. Whereas that can, and I don't mean it's intentional, certainly, but it is the pattern by which we socialize males and females.
Heather, you mentioned being a psychologist, and I would love just to dive a little bit into that because there seems to be lots of confusion out there. What's a psychologist? What's a psychiatrist? What's a clinical psychologist? What's a psychotherapist?
Yes.
And so, can we just spend a couple of minutes
Yeah.
really nutting down roughly what the difference is between all of these people who all have an incredible role to play?
Yes. Well, what's great is we're getting better at making sure that we're providing some sort of parameters around what names people can call themselves. So you know yourself that the word general practitioner is something that's registered name. Now, becoming a registered psychologist was actually something that only occurred in the 1980s. Okay, so it's a much newer phenomenon. Before then, you actually could call yourself a psychologist if you fancied it. There
Oh,
you
wow.
go. The downside is we haven't registered all of the names to do with mental health.
Right.
So you can actually call yourself a counsellor or a psychotherapist or a psychodynamic psychotherapist with no training at all. And there's the danger. And you have to
Okay, I didn't know that.
Exactly. And it's still in Australia. In other countries, it's better protected.
Right, okay.
But in Australia, no. So
Okay, I'll plead my Irish ignorance then. So I I actually did not know that. I
Right.
thought as a psychotherapist, you had to.
no,
Okay.
no. In England, the UK, this word psychotherapist comes along with a lot of training.
Yeah,
A
absolutely.
lot of training, but not in Australia. So we've got to be very careful in Australia when we look at the professional we're going to see, what their training and qualifications are. I do actually feel sorry for counsellors because there are some counsellors who have really like a master's in counselling and they belong to professional organisations. I think it's the Australian College of counsellors. I'm sure someone will ring in and tell you exactly what it is. But they have quite a rigorous process. But the layperson doesn't know someone who's registered with that organisation and someone who's not. And it's not. It's still not held under our APRA, which is what, of course, your registration is held under, as is mine as a psychologist. But counsellors are not. So we have psychologists that are registered and social workers are registered. Mental health social workers are registered, but not counsellors, not psychodynamic psychotherapists, not psychotherapists. Now, a psychiatrist is a different kettle of fish altogether because they've done medical training first, obviously, and then specialised in mental illness. And that's what's really important to know about a psychiatrist is they're interested in mental illness, which is why they still refer to the people that come to see them as patients. There's an assumption of illness. Registered psychologist, on the other hand, what we call experts in human behavior. So we can be working with people who are high elite athletes, CEOs, but as a clinical psychologist, my choice was to work predominantly with people with mental health diagnoses. So my training covers a lot of the clinical areas, but that was my specialization in the latter part. But my initial training, which is your general training, is across the whole spectrum of human behavior. So a psychologist is what we call an expert in human behavior, but some of us go on to specialize in clinical diagnoses, which is why a clinical psychologist will often work more with psychiatrists because we're working in that similar space, although they will medicate. Often that's why you see a psychiatrist, because we're looking at the medical ways in which we can impact the person's diagnoses, whereas a psychologist will look at a different type of talking therapy, behavior therapy. So they should work hand in hand by and large. And then, of course, you've got your other specializations in psychology, health psychology, sports psychology, organizational psychology. So if you see a psychologist, they haven't necessarily had training in clinical areas. And that's why we go back and look at not only what their credentials are, but also what other training they've done.
And an organizational psychologist is not someone who helps you be more organized.
No, I mean, they probably can help you in that area, but I think if you went to see them just for that, they might be a little confused. Yeah, and offended. Yeah.
Yeah, no, that was a patient asked me that. She goes, will they help? I find this person, will they help me be more organized? And I was like, oh, I would love that. But no, I don't think that's really what they do.
Love that.
So obviously you and I are both very passionate around that menopausal transition patient. And of course, they present in hundreds and thousands of different ways, but I'd love to chat through a few of the common themes that I see, if that's okay. So again, I suppose the first one is the person who comes in to see me and they are struggling with various symptoms, but their main thing will be, they'll say, I think I might have ADHD.
Yeah.
And we'll explore, and it might be because their child has just been diagnosed with ADHD and they're filling in all the questionnaires and they're thinking, oh,
Yeah.
this sounds a bit like me.
Yeah.
But it might also be that it's literally been that the perimenopause and the lack of sleep and the new onset anxiety has just tipped the whole house of cards down and they just can no longer juggle anymore. Can you talk to me a little bit about what's going on there and why do all these people suddenly think they've got ADHD or autism or whatever?
Yeah. Well, such a great question. And I think it's really important to explore it because, of course, we've got twice the number of diagnoses of ASD than a lot of other developing countries. We know that in terms of the number of diagnoses giving out in Australia, it's really skyrocketed compared to some others. Now, there's lots of reasons for that. Perhaps we're better at diagnosing it. Perhaps people are better at talking about it. People will question whether there's some funding mechanisms such as the NDIS, which has made it, I guess, there's some bonuses and benefits to getting a diagnosis that there may not be in someone sitting on the fence might say, in another country, oh, I probably am, but what does it matter? I can get some help from self-help books. I can talk to my GP. I can know this about myself. I don't need a diagnosis. Whereas in Australia, if you get a diagnosis, there is funding linked to that. That is quite lucrative, and I can understand that. For children, we know that the earlier we get in with a diagnosis, the better, because the outcomes are better. So for me, I think if there is an option to diagnose someone and to work with professionals, that's my preference. And I don't think it really matters that we have a higher diagnosis rate. If people are getting correctly diagnosed and getting the right treatment, perfect. ADHD, on the other hand, I think there's a lot of debate about this too. There is some thoughts that maybe we've just missed a whole lot of people. Potentially, we might be looking at maybe 20% of people who have ADHD. That would be at the higher end of the spectrum. But the reality is that we've got better at, as you've said, helping the community to know what the symptoms are. And because it's a highly heritable disorder, there's going to be someone in your family who has it, right? For both ASD and ADHD. So as we've got better at diagnosing children, as it's become much more socially, I guess, accepted acceptable, if you want to use that term. Kids are getting diagnosed, and then, of course, because of the heritability, parents are going, as you say, oh, I think I have that too. So if we think about it from that context, that we probably are getting a lot better at diagnosing. People aren't, there's not the stigma that used to be involved with it. In fact, it's in some areas because of the funding, it can be good to get a diagnosis and get on the treatment journey. However, for both of those as a neurodevelopmental disorder, the symptoms will be present from the time they're in utero to death. So with perimenopausal women, we've got to be very careful that if we're seeing a sudden onset of symptoms, that we don't go down the pathway of assuming it's ADHD or ASD, because we should have been seeing some symptoms across the lifespan. Now, because women tend to mask better, because we tend to have better social skills, as we've just talked about, our whole kind of sense of self is based around relationships, we won't show our symptoms in the same way as a male. Many females will have had, I don't know if you know the different types of ADHD. So we have 3 types. One is the hyperactive impulsive type, one is the inattentive type, and one is combined. Now, women tend to be underdiagnosed because we're the inattentive type more than males. Now, the inattentive type female isn't causing a problem in the classroom.
She's daydreaming.
She's daydreaming. She's just not getting her work done, but she's happy enough, and she's not flipping tables, and she's not poking the boy in front of her, and she's not running out of the class, and she's not jumping up on a chair. But she's not listening, and she's in a world of her own, and she might be perfectly happy there, but she's not achieving in the way that she's capable of. She's obviously not connecting with her learning experience. And a lot of those women who classically wouldn't have turned up on a current affair and who weren't sort of screaming out that their lives were falling apart or their families weren't, are then the ones that in perimenopause are getting picked up. Because the assessments should say, hey, this has been a lifespan issue.
Yes.
This isn't just suddenly starting. And a good GP, a good psychologist, talking to them about the checklist and how long it's been there for. It must be present before the age of 12 in order to get a diagnosis. So if you're in your perimenopausal period and you can get a hand on some of your some
bill reports.
Beautiful, thank you. And if your mum and dad are still around to help us know what went around that time, then we can look to diagnose. If it's just a new onset, we're looking at perimenopause issues and the brain fog, concentration issues, word finding issues that I just had.
And I came in.
Yeah, that's a team. That's a team. So we're looking at that as really what we want to sort of differentiate in that space.
Yeah, okay. And so if someone feels they've been navigating this and maybe they're trying to decide whether they maybe try some medication or not, what can we offer in terms of therapies to help someone, one, come to terms with that diagnosis, and also what strategies might they put in place to make sure that the next part of their life is even better than before?
So if you're looking at ADHD, should we look at that first? The evidence is very clear that if you do have a confirmed diagnosis, and as psychologists, we follow the science. We would like you to do a trial of medication unless it's otherwise contraindicated, because that has the highest level of evidence base. We don't pretend that we can do behavioral or cognitive strategies that can beat the medication that's available. So once we look at that, and some people may not want it, which is fine, but we need to indicate that would be the first port of call. Then we look at the strategies, and I'll give you a reference for Russell Barclay's book, Taking Charge of Adult ADHD. You know this book. And a lot of the strategies in there are about organization, about setting up reminders, lists, tasks that help a brain that's otherwise isn't wired that way, because you're looking at, don't want to get too much into the neuroscience of this, but the prefrontal cortex is really the area that doesn't fire as well in someone with ADHD. So people often find it funny that you're on a psychostimulant, but you're only stimulating an area of the brain. You're not stimulating the whole person. So the stimulation is about saying, okay, I want my prefrontal cortex, which is decision-making, plan and concentration, to work better in order that I can, have the same sort of capacity of doing tasks as someone without ADHD. So we're looking with a psychologist on some of those behavioral mechanisms. And I like that book because what a psychologist will largely follow a lot of principles in that book.
I love Russell Buckley. I
Yeah.
love him. He's so good. His
He
talks,
is.
there's some like really old stuff on
Yes.
YouTube. Like it's like 17,
Yes.
18 years old, but it's
Yes.
really good. And he just gets it.
He does. He gets ADHD. I wouldn't say he's the guru, and Russell, I think you're fabulous, but not so much the guru on emotions so much, but that's a good, can't be good on everything. So, but he's great on understanding the ADHD brain.
Yeah,
For sure.
absolutely. I actually love that you touched on what feels counterintuitive. So people have got ADHD and maybe they are a little bit hyperactive or they're all over the place. And then the next thing is we're giving them a stimulant, which a lot of people are like, what?
Yeah.
And so it does seem kind of like a weird thing to do. And yet, if it is a true diagnosis, giving that stimulant is absolutely life changing.
100%. Because you remember the frontal lobe is responsible for inhibition.
Yeah.
So it's like, I want to flip a table. Okay, guilty. I like to do that. I would like to do that a lot of the time. But because I have a really well-functioning prefrontal cortex, that inhibition will say, actually, Heather, that's not okay. Now, with an ADHD brain, that message doesn't get there quick enough. It'll get there because a lot of these ADHD people will feel bad about what they've done following it. Okay, so remember, it's like a traffic light system, where my brain works with stop, think, do. The ADHD brain is do, stop, think, feel bad. And so we're really trying to get that back in the right order for these people. So remembering we're stimulating a part of the brain that involves planning, concentration, and inhibition as well, so they can not do the things that might irritate their friends or their family, or they go and buy something that they know they don't have the money to do, and hey-ho, the dairy, it's in the shopping basket, and they've hit buy, and then they've got to, obviously unwind that if they can. So yes, so that's why it's important.
As someone who went straight from pregnant to menopausal very quickly, my skin really, really deteriorated quite rapidly. Now, I'd always had a sensitive skin, but my barrier function deteriorated and I developed really very obvious rosacea. And this is something that I see day after day in my clinic also. So many of you reached out and asked what I recommend and why. I have to say that since I opened my clinic, I've been using a brand called Rationale. They're an Australian brand that have been around for about 30 years. And what I absolutely love about Rationale is the products. They feel very luxurious, but they're extremely scientifically derived. And they've got these ingredients called skin identical formulations. All the ingredients, the minerals, the vitamins, everything that's included, the proteins, the lipids have all been found naturally within the human body, and therefore they're recognized by the body. So the ingredients are really, really well received. I find that menopausal skins and perimenopausal skins are dry, irritated, and sensitive. And with this range, I'm able to create a bespoke skincare plan for my patients. If you're interested in getting some of these amazing products, head to rationale.com and use the code YOU at checkout to receive some exciting bonus samples with your order. I am going to take you on a little bit of a segue quickly because I just want to ask this question. Why do people with ADHD sometimes have like obsessions that are like, so, they're like, one of my children has ADHD and we seem to go from, it's an obsession on an electric bike, and that was the obsession for ages, and then we're obsessed with the electric bike and everything about the electric bike. And it could be something that lasts for weeks or months, but then suddenly we don't like that thing anymore. And now we've got like the new obsession is golf, and we have to have the best golf clubs, and it's all to do with golf, and it just seems to flip around a lot.
And so what was that? This is where when we get parents that saying, my child can't be ADHD, and I'll go, okay, so just tell me why, and they'll go, because she can watch television for hours.
I used to think that as I thought he can have ADHD because he can focus on his iPad for ages.
Yeah.
I mean, even I thought that.
Yeah. So there's that over focusing that can come, and again, it's because it's attention dysregulation. We call it attention deficit, but it's sort of the deficit is in the ability to regulate attention. So when the hyperfocusing is because I can't regulate that, now's the time to stop, or the regulation is now's the time to pay attention, and I can't do that.
Yeah.
So it's like with most of the the psychiatric diagnosis, it's too much or too little. And it's not hitting that sweet spot in the middle. So there's over-focusing, which, as you say, can be on anything that takes their fancy at the time, without that capacity to sort of weigh that up with other things that might be in their world and maybe show them that this is a pattern for them, that maybe this is something they've done before. But because of that dysregulation, they will get that as they get older. But of course, those things will often be a struggle for the rest of their lives, just because of the way their brain works. And with a lot of the neuroaffirming material and podcasts that have come out now, what we need to do is make sure that we realize that that is not necessarily something they have to see as a struggle. It can also be a strength for them.
Yes, to try lots of things. I actually did another podcast, which is amazing. And it was with a doctor who has ASD and ADHD. And she said, but why does that have to be a bad thing that you
Yes.
don't stick? Is it not? Why can that not be a positive thing that
Yes.
you try lots of things in your life? And I was like,
With great passion.
yeah, I was like, okay, maybe that is true. Whereas I think it's been ingrained into me as a child. Like if I joined the Brownies, I had to stay at the Brownies. If I started gymnastics, I had to stay at gymnastics. I went to Irish dancing, I wasn't allowed to leave.
No.
That was that kind of the rules in our
Yeah.
house, that you had to stick with things.
Yeah.
And so that's kind of been really ingrained into me, that equals good.
Yes.
Sticking with something is good.
I love that. And you know what, Shauna, it's that reminder, isn't it? That I don't know how old you were when that was ingrained in your brain. And now I know you're over 30.
Only Jack.
And it's really making sure we do understand that some of those early learnings, those early patterns, those early messages really influence the brain for the rest of the lifespan, which is, again, why we want to get in and understand cognitions that developed in childhood and how they're impacting on the self now. But also, as I said to you, with ASD, ADHD, where we can get treatments that start earlier, the better for those people. But doesn't mean if you're in perimenopause, still helpful. So there's the diagnosis.
Okay. Next group of women I see a lot in perimenopause are women who've got awful anxiety.
Yeah.
And they can be sort of two groups. One who've always been quite anxious and it's now worse than ever. And then another group who've never been anxious and they are literally feeling like everything is terrifying. One of the common ones I find here on the Central Coast where we live is that people who've maybe lived in Sydney their whole lives, they've moved up here, suddenly terrified of driving in Sydney, whereas it never bothered them at all. Or suddenly husbands and partners are having to drive them to appointments because they're actually scared of having an accident in the car, and they know in their own mind that they haven't had an accident, they haven't even had a near accident, but they're just completely paranoid about it. But this anxiety is very, very troubling. I have had patients give up their job because they've become too anxious to even go to work, or too anxious to do a presentation that they used to always give every month at work. They just can't do it anymore. What is going on there?
Yeah, it's multifaceted, as you said, and I wish I knew the complete answer to that. And the research, as we know, is lagging well behind the actual women's experience of it. We know women are having this, but we're talking about it, and now they're starting to research it. We know that hormones impact our mood and our sense of safety. So it's our risk of threat is influenced by our hormones. Okay, so we can both lower our mood and get a higher sense of threat. So you're talking about that cohort that aren't depressed, or they may be depressed if this goes on for a period of time, but also that sense of threat and what's safe and not safe is exacerbated during this time. Now, we think that's to do mainly with hormonal changes. So what happens is the amygdala, which is the part of the brain that senses threat, seems to be on higher alert during this sort of perimenopause period. So what, as you say, used to be a neutral experience, or maybe if we looked out of 10, maybe a 3 out of 10 in terms of level of threat, 10 being the most and 0 being none, suddenly this thing's a 6 or a 7. So, as you say, with two different groups, it's very interesting. So with the group that's never had anxiety before, they're slightly easier to treat because they have an awareness of cognitions that told them something different. They have an awareness that maybe this isn't a fact, because part of cognitive behavior therapy is helping the brain figure out what is fact and what is just being produced as perhaps, a biological process. What is fact and what isn't. And for these women, it's easier because they can sense that, well, easier, I didn't say easy. It's easier because the sense that I know as a fact, I am a good driver. I've always got a sense that I can navigate those Sydney roads. I've got a sense that I am capable And we can then use that to sort of generate, well, what's different now? What do you think's happening now? And is this a feeling rather than a fact? So we're giving these women the concept of seeing this as a choice, because otherwise when those thoughts come up very rapidly, we see them as the truth. And cognitive behavior therapy is us stepping back from that, observing those thoughts and having choice. Because if we do not give women choice inside their own brains, they will then work on that as if it is a fact. So I can't drive anymore. If you don't challenge that, then that becomes a fact.
Yes.
I can't possibly drive in Sydney. No challenge. The brain sees that as a fact. The brain is stupid and clever all at the same time. It wants to help you. So if you have a thought, I can't drive in Sydney anymore, it'll go, okay, well, let's not do that then. Let's get a plan for not being able to drive in Sydney, and it'll just go down that pathway.
Yeah.
Whereas if we see ourselves as, those of you who've seen the movies Inside Out, where it really gets that idea of there being a controller as being self, and I can observe my thoughts, I can see what they are, see what they're saying, and then have some choice about whether they're the truth or whether they've been generated by an adrenaline surge, changing hormones, perhaps something someone said to me when I was younger, but I have choice now what I do with that thought.
Yeah, absolutely. First of all, love Inside Out. Love that movie. It's so good.
Yeah, that panic attack and that was just nailed.
Oh,
So good.
so good.
Yeah.
CBT, you mentioned that. Tell me, what is that?
What is CBT? Well, it's such a funny one because I've got lots to say about that probably aren't politically correct. So I'll
Go on then.
Yeah, okay, let's go there.
Be a rebel.
So let's go wild. While talking about CBT. Wow. So cognitive behavior therapy. So when we were sort of moving away from perhaps some of the psychodynamic principles of Freud, and most people would have heard of Freud, and we started to look at some principles for what shaped emotion that were a little bit easier to understand and to formulate, to explain to our clients. And of course, that the wisdom is that, of course, our thoughts have a big influence over a lot of the other systems in our body. So if you were to say, something like, I can't handle speaking to microphones, that would have a cascading effect on you. So you would also start to feel differently about talking to me today. You would also have different emotional experience. And what your cognitive processes will be, including images, might be that you're running out of the room. You might see yourself finally not appearing out to say. So your cognitions can have a significant impact on a lot of other networks. And there is an interplay between them. So the early CBT specialists sort of said, well, your thoughts determine who you are. Your thoughts determine your actions. Your thoughts determine, whether you're able to achieve things or not. And it was a rather simplistic process. So it basically said, if we can identify the thoughts that you're having, that can change your behavior, which can then go on to change your emotions. Now, because everyone comes to therapy to change how they feel. Right? They want to feel differently. We only have so many mechanisms to change how people feel. And the early cognitive therapists have said, well, we need to change how you think. Second generation is a lot more sophisticated than that and follows the science. So what it's saying is that, let's just say if you were in a car accident, God forbid that you would be, and the color of the car that hit you was the same color as the jacket I'm wearing. Okay, then I come and see you today for this podcast and you see the jacket, you only were hit 3 days ago, it's the same color. Before you've even had a thought, you've had a biological reaction to me. Now, that is the first reaction. That's not a cognitive reaction, that's a physiological reaction. So the second wave has said, let's take this into account. Fortunately, second wave therapies also take into account things like beta hormones. Your hormones will also change your mood states. And so now there's this sense of feeling depressed. You didn't have a cognition first, you had a feeling first. That, if we're not careful, will go on and influence your cognition. So now in the second wave, we're looking at the interplay much more between physiological reactions, emotional reactions, behaviors, and cognitive processing, including images, including sensations, because we know a lot of trauma relates to the olfactory sense, which of course is the one that first hits the brain. So we know that smell is very important in trauma. So we brought those in. So that's important. And then the good CBT therapist will also track that back to childhood. Yes, because as we've talked about, you with your swimming pool and you with your sense of good girl, etc., they're all related to childhood, where the brain is 90% of its adult size at the age of 5. The neural networks that determine who we are largely formed by the time we're 4. Attachment patterns in terms of the sense of I am, and others are formed, but largely by about 11 months. So we know that those early interactions are incredibly important in terms of how that person goes on to interact with the world. And if we don't track back, we're missing a large piece of the puzzle for that client in giving them some tools and strategies to have choice. As I said, I know when I was younger, I wasn't safe. I know when I was younger, people hurt me. But I have choice about whether I continue that today. Now, again, I didn't use the word easy. I said we have choice, and that can take some time to develop. But being that person that can be aware of physiological reactions, being aware of emotions, being aware of cognitive processes, and sometimes being aware of what we think is sort of more like an unconscious behavior, like that sort of sense of that drawing back from someone who might have physiological characteristics that remind you of an abuser or someone else. That's a behavior, then we can have choice over whether we do that.
Sometimes I have patients who will say things like, oh, I've got a really good friend or mother, sister, insert whoever, and I talk to them all the time, and so I don't need to see a therapist. And my really simple way of saying why I think everyone should have a psychologist personally, and that's just a thought. But I think that what is different than your friend, your mother, your neighbor, whoever, is that in that room, you can be 100% honest without worrying that they're going to be offended
Yep.
or worried or upset, or you're going to stress them out, or that they're going to think differently about you because of what you've said. So that's kind of how I try and frame it. Is there anything that you would add to that as to why it is different talking to a psychologist?
Okay. So,
Apart from all the training, of course.
yeah, but apart from that. But no, I think you make a really good point because it can cover two things here. One is it's really important to have a good enough relationship with your therapist. So relationships matter. So if you've got some really good girlfriends, whatever, that's wonderful. And if you can relate to them, great. So they might be your first port of call because relationships matter. However, as you said beautifully, the goal if you're in a relationship with someone is to maintain the relationship. No one wants to lose a relationship with their mom or their sister or their bestie, which means that that other person may not be in a position necessarily to challenge some of the story that you're sharing. They may not be in a position to suggest maybe doing things differently because the goal will be to keep the relationship. The other thing also will be that you're mindful of offending that person and that person offending you. In relational stuff, we're equal. So I get to share my story, you get to share your story. That's equal. But if you've got a really big problem and someone says, yeah, I know, I when I walked my dog the other day and I couldn't find anywhere to find another poo bag, it was really stressful. And the other person's just lost, a family member. Because there's that need for equality, those things can actually really get in the way of that person actually finding a place to really validate their story. As you said, it's not equal in a therapeutic relationship. The therapist is purely there for the other person, and you don't know often about your therapist a lot about their personal life because actually it's irrelevant. So the relationship matters, the fact that that person's important. If you've got a therapist sharing too much about themselves, I would question whether it's a healthy dynamic between the two of you. But anyway, apart from that, so what you're looking for then is the skill base that therapist brings. So again, that's when the training comes in for how to challenge someone else, how to use the strategy that's appropriate for that person, and that'll take into account a lot of the things which we use in motivational interviewing, which is whether you've got a client in front of you who's at the pre-contemplation stage, contemplation stage, planning stage, or action phase of wanting to make change. Now, if you don't know how to assess where that person's up to, you might come in at the wrong phase, and therefore you'll have a mismatch with what that person's needs are. And of course, I would presume that most friends, aunties, sisters, whatever, aren't trained to know what intervention is required and at what level.
Heather, obviously I've been with my family and kids to your amazing practice. I'm happy to say that. But I think people sometimes have in mind that going to a psychologist is going to be a bit like an episode of Fraser Crane and that they're going to be lying on a black leather
Yeah.
couch and that it's all going to feel a bit weird and
Yeah.
awkward. can you tell us what it is like? Should you expect when you go into an appointment?
Yeah. Okay. So, no, it's not like that. At some point, you may do some relaxation activity, but what those things, those shows largely represent sort of very old school psychiatric kind of idea of the types of therapy that a psychodynamic therapist might do. Now, we don't tend to use those in our practice, largely because they lack evidence base for being an
I have
intervention.
not seen any black leather couches, I have to
Nope.
say, in your
No.
place at all. No one offered me to lie down.
No, no, that's right. And that wasn't just because it was you. So what you can expect is all of our psychologists are well trained to do an initial assessment. So which means we've gathered some background data. We've usually done some screening to sort of just make sure what's coming in the door and make sure the right person is matched with you, because different psychologists have different types of interest and different areas of expertise in younger children, older people, perimenopause, trauma, etc. So if you're in going to a practice, there should be some checking to make sure the person that you're seeing matches your profile and your needs. If that's not there, then I would say just be a little bit cautious, because although psychologists are trained to work across the lifespan, as we get into our careers, we really need to be sort of making sure we're sort of got some areas covered more than others. So just check on that. Screening instruments are also really important. And then the other thing is to be mindful that there's going to be a little bit of paperwork, because things like confidentiality, consent are all things that we need to get from you before you enter the room. Your psychologist will also check on those as you enter the room. Because we're a registered health provider, we are obliged by law to cover a range of things related to confidentiality. So that can be a really awkward way sometimes to start a conversation with a psychologist, because you think you're going to go in there and just start talking about your problem. But you need to know that there might be legal ramifications if you do, particularly if you're a separated family. We need to let you know that these are the parameters under which how that information is held, and to make sure that you know that, so that when you share information, you know what's going to happen to that or not. And that gives people choice. Consent is also really important in the sense that we're going to ask you a lot of questions, and you need to know that you don't have to answer, And so the first bit should be setting up the parameters. Then really what happens next, it will be an assessment of risk at some level, particularly if you come with a high-level distress. Risk to do with children, so mandatory reporting, child abuse, risk to self in terms of suicide, and risk in terms of anything to do with it's quite significant legal matters. Once that's out of the way, then we're going to be looking at, just to help us understand why you're here. And then a good psychologist by the end of that should, or else I'll give you two of your homework, what are your goals? Because a good psychologist is working with you. It doesn't matter if you have OCD, PTSD, ADHD, ASD, or all of them. If what you want to actually get out of therapy is you want to get along better with your mother-in-law, then that's where we go.
Yeah.
You could be, washing your hands 100 times. You could be, completely disorganized. But if that's not what your goal is in therapy, then it's not my job to go there with you. That said, and the first thing is to manage risk and then develop a program that's what you want to get out of therapy.
Okay, that's so helpful. I just wanted to touch a little bit on something you mentioned there. We did a really great episode with a local divorce lawyer who was amazing. And I do have women who are afraid to see a psychologist in case they will disclose they're depressed, or perhaps they're drinking too much or whatever, and they're really worried that this is going to be held against them in court. And she was actually quite reassuring, and she said, but actually going and getting that problem dealt with, the fact that you're going to therapy and you're seeking help and you're getting support, would actually be seen as quite a positive thing. And therefore, probably people should not think that they shouldn't go and see about their X, Y, and Z problem in the concern that it might be held against them. Would you agree with that?
I've had the whole spectrum of experiences with that, and I want to be really
Oh,
honest
of
about that,
course.
because as much as I would want every woman to feel she could go and get help, I certainly know of times, and I don't mean to scare people, but it has been used against the woman, and I can there's a number of cases where that has happened. So I think we need to be very mindful that that is a possibility, and depending on the ruthlessness sometimes of an ex-partner or of their lawyers, it can actually be a real factor. So I would just say be mindful about that when you are engaging with a psychologist. And I think you can have a conversation with them about your concerns, remembering that a psychologist is required to keep notes that reflect important clinical components. A good psychologist who is aware that the potential, which is why we always ask, is this a separated family? We make sure, are there any legal things going on? We'll just be careful in how we keep those notes to things that are therapeutically necessary, but don't include anything that might be detrimental. But certainly if you're attending because you have anxiety or because you have depression or because there is alcohol, we can't determine how your ex's lawyer might use that. So we just want to be really mindful about that.
Okay.
Yeah, and balance up the benefits versus the risks for that beautiful mum.
Yeah, absolutely. And in fact, that actually brings me to the probably another next substantial group of women that I see in that perimenopausal, menopausal period where relationships are deteriorating.
Yeah.
And for many reasons, it can be that the woman is irritable, angry, anxious, struggling, not wanting to go out, feeling uncomfortable in her skin. She doesn't like her body. Sex is painful, intimate relationships almost impossible. So we have that scenario. For whatever reason, the relationship is breaking up, particularly one that's been maybe going on for a long time. I'd love to know, you've obviously dealt with this so many times. Do you have any sort of themes or tips or things that you wish people knew, or perhaps that they could do differently, or what they should or shouldn't do?
Yeah, I mean, because it's broad spectrum, isn't it,
course.
for the reasons. But I think it almost it goes back to where we started, which is we need to, I guess, armor up with being someone that exists not just in relation to others. And I mean, as a psychologist that works predominantly with women, all of my work is around be in relation to others, but also be in relation to yourself. Because if we can have that relationship with self, then the other bits are bolt-ons that are fabulous, but we don't fall apart if those aren't functioning. I mean, in a lot of ways, we will say, you're as well as your healthiest or your unhealthiest relationship. So relationships matter, but they can't be our everything. And so with women, it's about getting back to, okay, what's my relationship with self like? How can I get this back on track? How can I make sure that no one can change how you eat other than you. No one can determine whether you exercise other than you. No one can determine whether you have hobbies other than you. No one can determine what goes in your mind other than you. They're your choices. And I want to take women back to that being something that no one can change other than themselves if they take that leap, and really getting that back on track. And I think it's really important that women do see themselves as really a beautiful being, regardless of what their skin looks like, what their belly looks like, whether they've got kids living at home or not living at home, whether their husband is towing the line or what he's doing. We've got to get back to celebrating ourselves as people across the lifespan, not just whether we're in relationship with other people or not.
Yeah.
Get the relationship back with ourselves.
Yeah,
Yeah.
absolutely.
Didn't say that was easy either. Didn't say that was easy.
Any tips, or I mean, you and I both have this lifestyle medicine qualification, which I just absolutely love, preventative health. I know that you help women navigate weight.
Yes.
We've talked about this a lot. Obviously, I do as well. I would love for you to speak to the women out there who are struggling with weight. Everyone wants a quick fix.
Yes.
I mean, we all do. We're all guilty of it.
Yes.
I went to an event a few weeks ago that you presented, and you had such great insights. I would love if you could share some of those, because I have to say, in the top 3 reasons that I see women, it's their weight. So poor sleep is probably number 1, or inability to sleep.
Yeah.
But definitely weight gain, poor body image, loss of feeling of control over their body, is a big issue, and confidence plummeting.
Yes.
And I absolutely love your take on this. So I wonder, would you share a few of your nuggets for
Yeah,
us?
well, what I think one of the things is we've got to look, we've talked about relationships, is look at our relationship with food. What does food mean to us? And really, when the women I work with who are most at risk of their weight getting out of their control are those where it's at the end of the spectrum, where it's the only thing in life that brings them joy, or it's the only thing in life that takes away their pain. So food to me is almost just the vehicle under which they manage their emotional distress. For someone else, that could be alcohol. For someone else, that could be gambling. For someone else, it could be social media scrolling. But for a lot of women, food comes to represent this. And I I say often to women, that kind of concept of, when a man looks at a woman's body, he gets very excited and aroused. And I say, when a woman walks in to the most amazing patisserie, she gets excited and aroused. So that's so funny. But it's true. And so what often arouses women is actually food, this kind of the kind of concept of eating something really quite delightful. And so what we've got to look at is, do we have any other ways that bring us pleasure? As you said before, because we're often empty nesters, because we're struggling in our relationship with our husband, because we know that our girlfriends are often similarly minded, so they will often prioritize the relationships with children and husbands over the female gang, which does start to change as our kids get older. So we do start to have some bit more groundswell of women. As you know, I know you do your women's retreats, but when kids are younger, men are good at still going away with their mates, regardless if there's 4 kids at home, regardless of if everything's hitting the fan, regardless of what else is going on. That weekend away is still going ahead. Now,
You are so right. And I'm
yep,
just, I'm going, I was that stupid
yep,
mum who I didn't go away on
no,
any of the girls' trips
no,
or any of the ski weekends when I
no,
lived in the UK.
no,
I was like, no, I'll
no,
stay at home and be with the kids
yep,
all the time.
all the time.
And do you know what? My kids don't remember.
No,
So if
they do
anyone's
not.
listening, go on the
Go
weekends.
on the
They won't
weekend.
remember.
And it's the groundswell of everyone supporting each other, because the blokes do. The blokes will give each other a hard time if they don't go.
Yeah.
Absolutely, they will. Whereas women don't give each other a hard time and say, come on, this is important to you. Be part of your female tribe. Stay connected, because they're going to be with you, during really tough times. And you would know, during some of the tough times during perimenopause, we need our female friends. But we needed them in the earlier years too, but we just didn't get into the habit of doing that. Very hard to prioritize self. So I can't remember where we were going with this one, but yeah, women, yeah, find each other and make sure that you keep that tribe going, because we have to be able to connect with each other. What was the question? What am I answering?
Got to me.
We just got into women, you need to have girls' weekends, and we got excited.
I can't remember.
This is brilliant. So we answered that question so well.
Yeah, that we can't
Yeah,
remember what the
can't
question
remember
was. Sorry about that, anybody listening.
Yeah.
Okay. Is
Yeah.
there anyone who should not have therapy? Or is there a time of life that you should not go into talking about things?
No, everyone can benefit from a therapist, but what you've got to be very mindful of is finding the therapist that can understand what stage you're up to. If your therapist can't assess that you're at the stage where you actually just want a place, as you said, different to a daughter, a sister, a mother, where you just have that free space to download, that you actually loathe those people in your family, where you loathe your husband, where you loathe everyone. And they're not there to judge you. They're just there to help be a place for you to vent and to listen and to work out some of those processes in your mind. You're bringing from the unconscious to the conscious. You're getting a space to actually look at all of those thoughts, repack them up in a way that helps you to feel like, okay, I can leave here knowing that thought was probably feeling based. I could probably let that go. That one has got some really important meaning to it. I need to follow that one up. So it's a place to unpack and then to reorganize, because it doesn't require your therapist to do anything. A therapist has to really work with that client on which stage they're up to. And then some therapists, if they can't assess that, then someone else will be at a planning stage of, I really want to look at making these massive changes. And they'll say, All right, well, let's just talk about that for a while. No, this person's ready to make some changes. So what you're looking for is a therapist who can work with you on what stage you're up to and whether you're wanting a place to unpack things, whether you're at the stage of wanting to plan change, or whether at the stage where you're actually really ready to do something different. So yes, there is a therapy for all stages of that, but you just have to find a therapist that can help make sure that they find that with you.
What about women who've had severe childhood trauma? Is there ever a time when they shouldn't go back and revisit that
Oh,
trauma?
this is such a good question. Oh, because this irritates me with the way that some people talk about this. You only have to go back to your past if it's impacting your present. If you've managed your past, and that is very possible, remember, not everyone gets PTSD. Not everyone has complex PTSD. If you want to understand the difference, those we can go there. But it's really important to go. Some people will just be able to make sense of that. Like, it's not what happens to you, it's the meaning you make of it. And that's what's really important. So if I'm abused by my next door neighbor and I develop the cognitions, I'm a bad person, I'm unlovable, I'm disgusting, as a result of that, that's likely to impact on my present.
Yeah,
Okay, that makes
makes
sense.
sense. Yeah.
If, however, during since that time, I've got my sense of that is what a horrible human being he was. My parents needed to have protected me more. I was a beautiful little girl who deserved better. That's going to have a very different impact on how I'm presenting now. So we only go back to the past if it's impacting on the present. We have a look at what the impact is, and then we go back there to unpack that. If you come to me because you've got you're struggling with anxiety at work, and I have a look at those cognitions, it's got nothing to do with your childhood. I don't need to go back there.
Yes.
So we only want to unpack that if it's impacting the present.
And do you believe that you can shift that narrative so that someone who has had awful childhood trauma, let's say they've been abused, and they have taken that narrative that it's all about them and how awful they are, you know, do you think it is possible to shift someone to the point where they actually believe that they make the adults take responsibility and they take the responsibility away from themselves?
You just described my normal clinical day.
Yeah.
Yeah.
Amazing.
Yeah.
Okay.
That's what we do all day.
Okay. But a process of weeks, months, years?
Yeah. Yeah, absolutely. And it also depends not only on the severity of the abuse, it depends on the meaning that was made of it. As I said to you, we don't compare whether one abuse was more than the other, but some people have had years of abuse from multiple people. And again, it's just to say that that is likely to have more things for me to need to go back and to manage. Often those people then go on to have difficult relationships during their adolescence. Again, something we need to unpack and manage. Then they will often go on to have, marriages or relationships in their adulthood, which then need to be unpacked and explored. So depending on the number of layers, how long is a piece of string? It's as long as that person is willing to work with me to unpack all of that. However, because there is that common thread, often of cognitions that I'm not safe or I'm not worthwhile, once we start to unpack some of those threads, a lot of those other ones will undo, and you don't have to go back to every single event in order to manage that, what we're doing adaptive information processing.
Okay. My slightly fuzzy brain has remembered what we were talking
Oh,
about
well done
whenever
you.
we went on a
Yeah.
segue. We were talking about weight management in women. And then we went on it, and we were talking about so how we can have joy from food or we can use it as a soother.
Yeah.
If you don't mind, can we just circle back and
Sure.
talk a little bit more
Yeah.
about weight management?
Yes.
Because this is a big
It is
issue.
big, and I'm glad you brought it back.
Sorry, I mean, I don't really know how we ended up where we did, but hey.
I do, because I can make the link. So what we were talking about is what brings you joy. And if it's only food, because everything else in your life has gone away, or you have let your play go, then you've got to start to bring joy back into your life, so that food isn't the only way that you experience positive emotions. And if you're working with a psychologist, we'll be working with you on keeping a bit of a diary. It can be a little bit annoying, but just got to get through that first bit, where you're looking at how, at the end of the day, perhaps you're getting ready to leave work, and you're thinking about, I'm going home to an empty house. That's negative.
Yeah.
You could imagine that would start a whole lot of cognitive, emotional, biological processes. And then you think about the packet of Tim Tams. And that process changes. The dopamine hit kicks in. So we have to work with you on those when that feeling is starting and what your alternatives might be to actually feel okay about your evening. That doesn't involve the only way I can see myself enjoying myself this evening is because of that packet of Tim Tams. We've got to get in the way of you making that link because that dopamine link is very, very strong.
Yeah.
So we're going to have to really work on some of those alternatives for you feeling. And if you haven't got any, then of course our job is to work with you on developing some other things in your life that can bring you joy.
Yeah.
Okay. So that's important. So the other way is to look at those people who have, like we were talking about abuse just a minute ago. The only way they can get away from feeling all of the awful feelings they have is through replacing that with maybe the same packet of Tim Tams. So they're the people that we've got to go back and say, okay, we can experience sadness. It's okay to experience tension because tension in their body is often associated with the trauma. So it's the helping those people get back to I can have a relationship with my body where I don't have to dissociate away from that or try to get away from all the negativity through food. And it would be the same because you would have a lot of people here that come to see you as with me where alcohol is in the same.
I was exactly going to say the same.
Yeah.
And I have it with people a lot of women in this category who are not sleeping.
Yeah.
And they're using alcohol
Yep.
to try and help them sleep, which ironically seems to make
Doesn't
the
help
whole things worse.
Yes, at 2:00 in the morning, ladies, you know the time. So it helped you maybe get to sleep, but you're bang awake at 2 or 3 in the morning and you're not going back to sleep. Yeah, absolutely.
And whenever you are approaching someone who maybe is using alcohol as a crutch to either sleep or to numb themselves, how do you approach that?
Again, I would be looking back to what is it that's so hard for you that you don't feel you can cope with without alcohol or without food? What is it? Because we need to talk about that and just be sure that this isn't a story that you've told yourself perhaps many years ago. I can't cope with X, I can't cope with Y, I can't cope with this body sensation, and really just checking that's still true now because women are incredibly strong and incredibly resilient, and what we can cope with is extraordinary and enormous. We need to increase our sense of resilience because it's very true and say, yes, I can get through tough times. And when we can just see that we call it surfing the wave, that often when those big feelings come, we think we've got to do something when it's at its peak. But often if we can let it just pass, if even giving yourself 20 minutes, often it will have passed, so long as you're not just sitting there staring at your glass of wine. I mean, that's not fair on yourself. You need to use other activities. Perhaps it is going for a walk, perhaps it's looking through some journals, perhaps it's reading some articles, listening to some music. That peak that it gets to where you're absolutely convinced you need to eat or drink alcohol will reduce. And then if you look at it being that there might be some alternatives that, okay, so you're not going to eat the whole packet of Tim Tams, why don't you just set aside a moderate amount that's actually within a healthy eating plan or have that one glass of wine rather than throwing back a bottle and then you're not going to influence, your sleep and you're not going to have the problem with the number of calories that you've eaten. So you can not necessarily get rid of it, but have it within a healthy eating plan.
Yeah. Okay. Heather, I want to just touch on a subject that I know both you and I are very mindful of, and we've both been involved with a charitable organization called the Debbie Gaunt Foundation, which really has highlighted that mental health. And the reality is that for sometimes people, mental health ends up with being fatal.
Yes.
And I wanted to talk a little bit about feeling suicidal in this period of life because it's definitely, I wouldn't say it's really, really, really common, but it's common enough that, women are often relieved if I bring it up to them and they'll say, I've just been having the darkest thoughts. I've never felt like this and I'm scaring myself.
Yeah.
And I know that we don't really know what's going on. It's clearly, there's so much more research to be done. But, the reality is that this is a really peak time for women to suicide.
Yes.
I know that there are women out there listening who are probably thinking, that's me.
Yeah.
And sometimes it's a cyclical thing that they're having these feelings. And then, I had one woman really recently and she said to me, I actually think I'm going crazy, she said, because honestly, she said, 2 weekends ago, she said, I was constantly thinking about, killing myself, that I couldn't stop thinking about it. And she said, and about a week later, she goes, I was making pancakes and cupcakes with my daughter and I was singing.
Yeah.
And she said, she goes, even I'm thinking like I am ridiculous. Like,
Yeah.
what is wrong with me? And she goes, but I felt really unsafe. Thankfully, she did tell her husband just how unsafe she
Yeah.
felt. But he was quite scared. He
Which
didn't really know what
yeah.
to do with her either.
Yes.
What should people be doing?
Okay. So let's just firstly, let's normalize this. In so that some of those women at home don't feel like there's something particularly wrong with them. We know 1 in 5 women during the menopausal period or perimenopausal period will think thoughts around life's not worth living. We know 1 in 5. Okay, so we know that what that translates to in terms of a suicidal thought, which is when that moves from life's not worth living to I actually am thinking of killing myself. So it moves to that. And so we think that might be around about 15% of women will have that suicidal thought at some point during perimenopause. As I said, the cognitions are not truths. They're by and large based on feelings and biological mechanisms. So we will often have these thoughts generated, but it doesn't make them true. And as you said, that beautiful lady who was observing her thoughts on one day that says, I want to die. And on another day, I want to have cupcakes and lemonade. And it's really making sure that we can sit back and observe our thoughts rather than seeing our thoughts as the truth. When we can educate women on, yes, as your hormones change, as your emotions change, some of your cognitive processes will change, some of your experiences will change in terms of kids leaving home, difficulties with husband, that will generate thoughts as part of that. Now, they're not facts, but they're certainly there. And then it's a case of, as I said, the choice becomes, if I have that thought, what am I going to do about that? And there's a whole range of things people can do, depending on the intensity of them, of course. But if we're at the point where you're just having a thought, and if we use one of the techniques that's in a lot of the mindfulness-based techniques, is it starts with "I want to die." Okay, that would be a very strong thought. If we put in front of that some awareness that self-recognizes that's something that's been generated, like it might generate, a sneeze, I'm having the thought that I want to die. Now that puts some distance in it. And then if you put at the end of that, and I'm aware that this will happen when my hormones change. I'm aware that this will happen at that time of the month. I'm aware that this will happen when my husband goes away for the weekend. So it's saying, okay, not only do I know there's a thought now, not a fact, I'm also aware of the processes that create this. And so when this happens, what I have is a plan that I've worked out with my fabulous GP, or I've worked out with my psychologist, counsellor, etc. When I have this thought, what I'll do is I will remind myself of all the reasons that I want to still live, like the fact that it will pass and I'll be making cupcakes tomorrow morning, or some of the other reasons I have for living, like my dog. I'll look at photos of family in Ireland or wherever it is that is a reason for living. Or I will challenge that by saying, this is the time that I actually need to talk to someone about this. Like this woman said, this is the point in time where I'll tell my husband so that he's aware of what's going on. Because if that thought changes to an action, we've got problems. Okay, so if a woman says, I want to die, it's a thought. It's there. She can hold that within that cognitive process. If that starts to become, and women, I want you to take this really seriously, that you're starting to think of a mechanism in order for that to happen, that is very serious. And that is when I will ask you to tell anyone, call Lifeline, call the mental health line, and you can put these at the end of your podcast, so that you can have someone else help you get some distance from those thoughts and someone else put some mechanism in place. Because when we're looking at this, ladies, we're looking at any plan that what we call a method. Okay. And then we're looking at your access to that method. So if you decide that you're going to get a plane to the UK and you're going to do it in a fancy place over there, that's the access is a long time away. But if you decide that you're going to use something that you can actually access at that point in time, now you're in a lot of danger. And that's when we really take it very seriously and you need to tell someone. They need to help you with that. The thing that's really important is that people do not commit suicide when they're with someone. We do this on our own. So if the one thing you can do is make sure you're with somebody else, please do that. The other thing that's really important is to look at your intention. And that is, most of us actually don't want to die. We just want the pain to stop. And I would say that's 90% true for 99% of the women I work with. It's just, how do I stop this pain? So if we're really clear that the brain is trying to say, I kind of ran out of ideas on how to stop the pain, the only thing I've got left is to die. That's the only thing I've got left to think of. Then let's just remind the brain that actually we don't want to be dead. We just want the pain to stop. And so the mechanisms that we need to use are actually working with a therapist, working with a friend who can just be our confidant for that period of time and then get us to a therapist, working with our GP to change our hormones, change our serotonin. Then the idea is stopping the pain, not death. And of course, the most crucial, women, if you're listening to this and this adds up for you, so you've got a method that you intend to use, you have access to that method, your intention has moved to stopping the pain to dying, and you plan to do it immediately, please call 000. We need to take this very seriously. Please call Lifeline immediately, the mental health line, and do something about that. But help is available for you. There is no need for you to die. We can work through this and we can give you the life that you want out there on the other side. We're very much here as a team to help you.
Heather, thank you so much. I just want to ask a question, and it's because I've been working with a family in the last week where we've been in this situation, and it was a male member, but there's definitely that feeling that if only they could have said to him, think of your mother or think of your wife or think of the pain that you're going to put your family through. Like, is that a good thing to say to someone who's actually thinking of doing this, or is that too much stress, too much burden for that person?
Yeah, it is, because you only use that if that's what the woman has signed up to being helpful for her.
Yeah.
Okay, otherwise you're just making her feel guilty. And by the time a woman gets in, or anybody gets to that suicidal ideation intensity, it's called cognitive narrowing. And they've absolutely convinced themselves that those people would be better off without them. Okay, so if they feel guilty, but they for a moment, but they also decide that, okay, that person is still better off if they're not on this planet. They won't have to put up with their moaning and their whinging and their tantrums and their hormonal all over the place, that this system is better off without them. They'll have a lot of reasons why they should die because they've got into that space. So if someone is at that stage of really seriously considering suicide, it's out of the hands of family and friends and needs to be with a professional. Absolutely.
Yeah. Amazing. Heather, I know there's going to be a part 2, 3, 4, 5. I've loved this conversation and I could ask you 100 more. I'm going to ask you one final question for today, which is if you could talk to 20-something Heather, what would you tell her?
Do you know what? I've been thinking about this one. I've had many different variations of it. You know what? I was happy with the one I came up with. Yeah. And it was, don't let what others think about you stop you making a difference.
I love that.
And I thought, that's what I want. That's what I would want her to know, because I'm doing that now. I could have started earlier, you know? But anyway, we're here now.
Amazing. Thank you so much.
Pleasure.
This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.